All right, good afternoon. So we're just going to go ahead and jump in and get started here. So I am Dr. William Gallentine. I'm a pediatric epileptologist at Stanford University. And what we're going to be talking about this afternoon are who is actually to be considered for an epilepsy surgery candidate. So I'll be doing a portion of this talk, and then you'll be able to hear from one of our pediatric neurosurgeons at Stanford as well, Dr. Jerry Grant, and he'll give you some of his perspective thoughts as well. So we're going to go ahead and get started. So what exactly is epilepsy surgery? So this would be a neurosurgical procedure whose primary aim is to stop or reduce seizures and really improve the overall quality of life of patients with refractory epilepsy. How would we define refractory epilepsy would be the failure of two or more appropriately chosen anti-epileptic drugs used in their appropriate dosing with the goal of achieving seizure freedom. Any patient that meets that definition of refractory epilepsy should then ultimately be referred to a tertiary epilepsy care center, really to kind of have a discussion of the therapeutic options, including a potential pre-surgical evaluation. So what are our options once we found that we've actually met refractory epilepsy? Oftentimes we're going to start with anti-epileptics, and actually whenever you look at the first anti-epileptic that we choose, about 50-60% of that people will actually respond to that, and then about 10 or 15% will respond to their second, and then only 5-10% will actually respond to their third medication, with 20-30% of folks actually ultimately proven to be refractory. Once they reach that point, then you really need to kind of start thinking about other options for therapy. So dietary therapy in regards to be the ketogenic diet, a modified Atkins, or low glycemic index diet, which can be actually very effective. I mean, about half those patients will be about seizure-free on diet, with about 10 or 15% becoming seizure-free. But then epilepsy resective surgery also should be considered, as this often is going to be the only curative option that we potentially may have when it comes to refractory epilepsy. Palliative epilepsy surgery also can be considered. So this actually would be a surgery that's being performed in someone who are not actually able to find one particular focus, but may have multiple different areas of seizures coming from, and we feel that performing the surgery may actually still improve their overall quality of life. There's also then neurostimulation, which would be a vagal nerve stimulator, repetitive nerve stimulator, which actually records from the brain and provides electrical stimulations, as well as deep brain stimulation. So who is the ideal surgical candidate? This would be a person that actually has focal seizures starting in one location of the brain with corresponding neuroimaging abnormality, which can be removed without actually causing any new neurological deficits. Surgical outcomes are often optimized when patients meet this description. All of our initial evaluation then at that point is actually aimed at trying to identify these particular types of patients and really identifying where seizures are potentially coming from, and then is there an accompanying structural lesion. Importantly, not being the ideal candidate, although, doesn't necessarily rule you out. It doesn't necessarily mean we can't consider you a surgical candidate, including non-lesional cases, so cases without a spot on the neuroimaging. So what does a neurosurgical evaluation actually include? Well, we typically will begin with a consultation with an epilepsy expert, and that could be either adult or pediatrics. That person will then take a detailed seizure history, really aimed at determining what type of seizure you potentially may have, whether it is focal, meaning it starts in one particular spot, or it's generalized, meaning a more widespread onset. We often elicit other information such as the age of seizure onset, number of different types of seizures you may have. The description of the seizures actually is extraordinarily helpful in potentially providing localizing value. Triggers, in terms of what potentially may bring on the seizures, may be important. Impact of seizures on overall quality of life, including the impact of medication side effects. We may be discussing prior AEDs as well as current AED side effects, a birth history and past medical history, really searching for epilepsy risk factors, a family history, potentially looking for a genetic underlying reason for why you may be having seizures, and then a history for developmental regression within that, which may often push us towards a surgical intervention if this is indeed occurring. And then a social history. Does the patient have a job? What goals do we actually have in terms of lifelong aspirations? What is the living situation that we're currently in? What's the school performance? These are all things that potentially weigh into consideration where we're thinking about how we're going to move forward with the treatment. Physical exam is also very important as it has localizing value, meaning that it gives us a opportunity to assess function in terms of whether there's a visual deficit or a motor deficit or some problem with cognition. And this will be important as we potentially make decisions as to whether we would perform surgery in a specific area. MRI of the brain is something that we're going to want to see with all of these potential patients. If one's been done previously, we really want to assess the adequacy of that study and making sure that it was done without artifact or with the appropriate types of images that we would want, specifically an epilepsy protocol, which can kind of more clearly delineate particular areas that we might be interested in. And then also, how long has it been since the last MRI? We also want to review any prior EEG data that may be present. And then also would consider doing an inpatient video EEG. So whenever we talk about the MRI of the brain and epilepsy and candidacy, we often are speaking of potential lesions. And so let's see if this pointer actually works here. Oops. All right. So we're going to start with this MRI here on the right. And so this MRI actually has a very small abnormality present in the hippocampus. So this is a little area of the brain that oftentimes where seizures come from. And in this particular MRI, there's a small scar in this area. And whenever this particular abnormality is present, these patients are potentially could make good seizure candidates, seizure epilepsy surgery candidates. Seizures also can come from abnormalities such as this, which is a developmental brain abnormality in terms of an abnormal collection of nerve cells that actually didn't make it all the way out to the cortex, and that's called a cortical dysplasia. This MRI here actually has a more widespread abnormality involving this entire side of the brain that actually didn't develop appropriately, and that's called hemimegaencephaly. This MRI down at the bottom here is actually a neonatal stroke, so it's actually one where there was an injury before the baby was born that has resulted in actually absorption of this tissue here after it was injured with a stroke, leaving a very large deficit. This MRI here is normal, no lesions on it. And this MRI here is a tuberous sclerosis scan that actually has of a patient that has multiple different abnormalities present on both sides of the brain. Now the real question is of these potential MRIs, which of them are potential surgical candidates? And the answer is actually all of them, depending upon what more information we may gather. So no matter what your MRI may show, it is important to continue to ask the question, is there any way that surgery would potentially benefit? So then the next step is actually doing inpatient video EEG monitoring, and so with the goal being seizure characterization and localization. And so depending upon your seizure frequency, the admission may last anywhere from 1 to 7 days. Medications are often weaned, and then activated procedures, including sleep deprivation, are oftentimes performed. Usually we'd like to capture at least 3 seizures, if possible, as well as potentially capturing all the different seizure types if there's more than one present. The video really is quite important, as this allows us to actually have a detailed description of the seizures, which also has a bit localizing value. If patients are found to have focal seizures coming from one specific area, we then may pursue further testing, or if neuroimaging has a corresponding lesion, we may actually even recommend surgery at that point. However, if the patient is found to actually have a more widespread seizures, generalized seizures, or seizures occurring from multiple different areas, there may actually be a recommendation to not further pursue surgery at that moment, but actually further pursue medical management or another form of therapy. So sometimes our EEG will actually provide us information that's not definitive. It isn't really good enough to actually clearly localize where the seizures are coming from. And in those circumstances, MRI actually also might be negative. So there are some other types of testing that potentially can be useful for the localizing seizures and where they may be coming from. And this would include a PET scan, or also more recently a combined PET MRI, Ictal Spect, magnetoencephalogram. We may also consider doing functional testing, which is important to know what the risk potentially of the surgery may be, and may also help us with localization. So tests like neuropsych testing, functional MRI, WADA test, as well as visual field testing can be helpful. So starting with a PET scan, so a PET scan actually shows how our brain uses sugar. This is using a very low safe dose of radioactive tracer. It's injected into the patient's arms, and then it's uptaked by the brain. And it will show us how the brain is utilizing sugar. Not all the PET scans look the same, and depending on what institution that you're at, but they oftentimes will use various different colors to show areas of higher or lower sugar use. In between seizures is when we typically perform these types of scans. And what we'll oftentimes see is what's kind of evident here, where you can see that this side is darker than this side, that there's a focal area of hypometabolism, meaning that it's not using sugar well, and that oftentimes will correspond with where a seizure is coming from. More recently, PET MRI has been something that's been developed, and this is actually a 2-in-1 test that combines both the images from a PET scan and an MRI. It has several advantages to actually our more traditional PET CT, which we would perform, which it actually has a higher yield in detecting pathologic changes in about 50% of patients. It also actually improves the safety by significantly reducing radiation that we typically see with a PET scan of a CT. And there's also the convenience of actually, you typically have to get both these scans anyway, so there's the convenience of having them done at the same time, so avoiding separate appointments. A magnetoencephalogram, this measures small electrical currents that actually produce magnetic fields that arise from the nerve cells of the brain. This is actually somewhat similar to EEG, but there is some important differences. In particular, MAG is much less affected by the skull and the tissues around the brain, which really allows us to get better yield on the magnetic fields that are being measured, much less impacting than what we typically see with EEG. So it's somewhat more accurate. It uses the interictal spikes, so the little discharges that we typically see on an EEG in between seizures. It uses those to actually help determine the magnetic field of interest. And so if you're a patient that actually doesn't have a lot of interictal spikes on your EEG, MAG oftentimes may not be all that helpful. But this test does give us reliable information in regards to localization of potentially a brain function, including motor and sensory, as well as actually potentially localizing an epileptic focus. And so then they're actually able to take these magnetic fields and then actually map them onto the MRI, which then also kind of gives us some anatomic information in terms of kind of what structures are around those areas where the discharges are being generated, as well as is there a subtle abnormality on the imaging that may have been previously neglected. It kind of helps us hone into that particular area. The Ictal Spect is another study that oftentimes is performed. This too is a nuclear medicine study that measures blood flow within the brain. So a safe, short-lived radioactive substance again is injected, and then a CT is done right afterward. And so this is injected during the seizure. Once again, an area of seizure focus during the seizure will have more blood flow. And so it'll actually light up brighter on the scan. So you can see here, so this scan is on this side is actually the interictal scan. So this is done not during a seizure. And then the injection is done, and then the scan is then repeated. And you can see this red spot here corresponds with an area of increased blood flow, and this potentially is where the seizure is being generated. We then can actually further superimpose this onto an MRI, and this process is called SysCom. And so that actually gives you a very nice bright spot on the MRI corresponding potentially to an anatomic region of interest. Neuropsychological testing. This oftentimes is performed formally by a neuropsychologist. And really it's a way to kind of assess overall cognitive abilities, including intellect, processing speed, memory, concentration, problem solving, mood, and personality issues. This too can have localizing value in regards to an epileptic focus, meaning that there may be some aspects of memory that may be affected that may localize to one side or the other, or some elements of inattention or processing speed that may also point you in certain different directions. It also may identify a risk of cognitive impairment following surgery or memory loss. And it really also allows us to track potential progress over time and also to kind of develop post-op planning if there is a cognitive deficit that is to be expected. Functional MRI also can be used, and so to measure different areas of brain function. This really measures small changes in blood flow that occur during a specific activity. So a patient is actually put into an MRI while awake and then asked to perform certain tasks. And so it really gives us then some idea of potential motor function or language. And so this functional MRI here is one of a patient doing right finger tapping, and the left side of the brain controls the right side of the body. And you can see that there's actually this hot spot that occurs right over the hand motor area. So this is very helpful in planning and having discussions potentially for risk of a potential surgical intervention and what potentially might be an area that we might be thinking about operating. So a WADA test is a test that we actually often will do prior to surgery as well. And so this is really aimed at trying to determine a side of language dominance as well as to potentially assess memory. And what's done is that a arteriogram is actually performed where very much like you may be familiar with a cardiac catheterization where a radiologist will actually go in through an artery in your leg and then pass a tube that goes up to the heart, and you can look at the blood vessels there. Well, this one passes the tube all the way up into the neck blood vessels so that we can actually look at the blood vessels of the brain. And then during that period, then a radiologist will then inject a anesthetic into the brain, which actually then functionally puts half the brain to sleep. And during that period, then we are, as neurologists, are able to assess motor function as well as memory. And so if memory is intact when one side of the brain is actually asleep, then you know that the other side would potentially support that memory if you were to do a surgery. So it's another way for us to potentially assess that. And at this point, we're still looking for other techniques to actually provide us a way of assessing memory that's not as invasive as an arteriogram. Visual field testing can also be helpful, really in kind of determining whether actually there may be a pre-existing visual field deficit. So this is most important if we're going to be doing a surgery that's in the back of the brain where our vision is primarily located. And so if there already is a visual field deficit, much like you're seeing in this picture here, then we feel much more comfortable saying that we can take out that potential tissue. But otherwise, it does help us really delineate risk discussion. There's also types of imaging that we can do with MRI that actually looks at the visual tracts. And so that actually is depicted here. You can see these optic nerves and then optic radiations coming out of the nerves that then ultimately go back to the back of the brain. And so as our neurosurgeon is potentially planning a surgery, if he's going to be close to those, we can then have a sense for what our potential risk may potentially be. So what is our pre-surgical evaluation process? So really, after every patient with refractory epilepsy should have their video EEG monitoring and have a high-resolution MRI with an epilepsy protocol, as we discussed. We then may actually order some of these other studies that we potentially just talked about as part of our further surgical planning. But it's important to note that not all patients require all these types of testing. And it's going to be very individualized and tailored to that particular individual. So but once all this information is then gathered, the patient's case is then typically presented at epilepsy conference, which is multidisciplinary and involves the neurosurgeons and all the other epileptologists, oftentimes psychologists, who all come in and kind of discuss the patient and discuss whether this potential patient is a good surgical candidate and the best way to potentially approach them with a surgical plan. There's numerous different types of epilepsy surgery we may ultimately conclude that the patient may need. The first step, if we feel like that we may consider potential resection, might be a seizure localization surgery where we actually try to monitor from the surface of the brain or from the deep structures of the brain. And that's typically done one of two ways. One is subdural strips and grids, which actually requires a much larger surgery where you actually need to remove the skull and actually lay a surface of electrodes on the surface of the brain to potentially record. And so, but then more recently, we've been doing a lot more stereo EEG studies, which are actually less invasive, and electrodes are actually placed into the brain with depth electrodes through small holes that are assisted through robot guidance. And Dr. Grant will talk more about that here in a little while. And that too allows us to potentially map where seizures are potentially coming from. Different types of epilepsy surgery may be recommended. So a lesionectomy would be that we've looked at the MRI and there's an abnormality there. We've then mapped out where those seizures are coming from, and we can actually take out that one particular lesion. Cortectomy would be like one small area of the outside surface. It may come that we need to do a lobectomy where we'd actually have to remove a full larger lobe area of the brain. And it may actually even come to a hemispherectomy where you'd actually have to remove one entire side with a disconnection. Sometimes we'll actually do what's called a corpus callosotomy, where you actually will disconnect one side of the brain to the other and prevent the electrical activity from going across and resulting in seizures. Oftentimes we would do something like that if we don't actually have one area that we can successfully kind of take out. Subpupil transection is another type of surgery where we actually, again, we may found that our seizure focuses in a really important area that we know that we would cause a significant deficit if we aren't actually able to take it out, such as the language center. And so in those circumstances, sometimes what we can do is actually break up the connections of the nerve cells on the outside surface of the brain that really prevents the spreading of the seizure activity across the surface that would oftentimes manifest in the clinical seizure. More recently, we've been doing things that's pretty exciting in terms of being a little less invasive using laser thermal ablation, where we can actually put small catheters into the brain that then actually allow us to burn an area of the brain out, oftentimes saving a lot of other tissue that we typically would have had to injure doing surgeries to get to those areas previously. And then lastly, there's neurostimulators, which are offering another opportunity whenever a resective surgery is not available, in the form of vagal nerve stimulation, which is a device that actually stimulates the cranial nerves and sends the vagus nerve on the outside, and then sends electrical impulses up to the brain, which then can disrupt seizures, as well as repetitive neurostimulation, which is actually a stimulator that actually is providing stimulation within the brain. So a stimulator is implanted within the skull, and then it actually reads EEG and will apply electrical stimulation to the brain based upon the presence of seizures. And then lastly, more recently, even still, are deep brain stimulators, which are basically being placed into the conduit of the brain, the thalamus, that actually is then disrupting seizure activity. So multiple different options, as you can see, and in these conversations that we have as a team, we ultimately are trying to conclude what's the best for the patient. So then when we go back to epilepsy conference, after we've gathered all this information, we've had the extra tests, we may have even done one of the invasive monitoring sessions that we already talked about, and then we relay this information back to the family. We talk about what the likelihood is for surgery would make them seizure-free. We talk about if we can't make them seizure-free, what do we feel the potential benefit would be. And we ask, would that benefit actually really significantly improve quality of life? We talk about the risk of surgery and the potential post-op deficits. And it's very important to identify what your primary goals are of the surgery and whether these potential deficits may potentially impact those goals. So if you're someone who wants to drive, but we're going to cause a massive visual field deficit, and that's not going to result in driving, does that weigh into your decision in terms of you have a seizure? And so it's just really important to have a good understanding of the overall potential outcomes, and it's really essential in the setting of realistic expectations. So in closing, every patient that we see with refractory epilepsy really should see an epileptologist to discuss their therapeutic options with possible candidacy for possible epilepsy surgery. These candidacy decisions are very personalized, and depending upon the type and severity of your epilepsy, results of your video EEG, neuroimaging studies, and other supportive tests, as well as your potential desired surgical outcome, whether that's seizure freedom or improved quality of life. All of this needs to be balanced with the risk for potential deficits. So I'll end my talk there. And I will turn it over to Dr. Grant, who's going to talk a little bit more about the surgical interventions.
Hi, everyone. Interesting, everyone's over to this side of the room. Makes it easy, except for one. So we're going to talk a little bit about some of the surgery aspects and highlight some of the work we're doing in this area. Hopefully. Let's see. Sort of frozen here. Sorry about that. Yeah, it's sort of locked. Let me see. Sorry, everyone. One second. All right, sorry about that. So we're going to talk a bit about the fact, the first thing is that there is so many more number of patients that really would qualify for surgery than we, really get a chance to evaluate. This has been looked at around the world. We don't really understand why that is, but clearly access is a big deal, in terms of a patient, say, that has tried, 8 medicines with no benefit. Why aren't they referred to go further? There are so many other options now that we have. The epilepsy field has changed dramatically over the last decade, where prior to that, it actually was pretty static for about 30 years. So it's a very exciting time for epilepsy, and this shows how there are, so many more candidates. We think we get to about 10% of those who might need something done. Children are more likely to undergo surgery now at a very young age, which is super important for their development. So that's a key factor that we know the earlier the better. We used to not think as much about that. But this is something we have to keep in mind. And, why is that? And many people feel, well, surgery should be a last-ditch effort. We have to kind of rethink that as to why it's important and become seizure-free at a younger and younger age. Some people think it's experimental in terms of what we do. And there are some very innovative things that sometimes we don't understand, but clearly this is something that does work for certain types of seizures that we really feel we can make an impact. There are risks, and that's the hard part. We have to make sure we never hurt the quality of life of a patient by trying to help their seizures. It's not worth that. It's not like cancer where we just keep going and we're so aggressive. We can't hurt their quality of life. We don't want to affect their day-to-day, but we're trying to help. So that team meeting that Dr. Gallentine referred to is so important as we balance, how will this help that patient, in terms of going that next step? Is it really worth it to do these things? And some patients just don't want part of their brain removed. I can understand that. It's something that's a big deal to think about. But it's something that definitely can help them because that part of the brain isn't working well, and it actually is affecting the good brain. And that's why it's so important to think about this. This has been studied, in a class 1 evidence, we call it, for temporal lobectomy, which is the most common surgery done in the temporal lobe of the brain, which is right here. And this is a trial that is even back 2001 that showed basically with surgery, in terms of outcome versus medically, dramatic difference of seizure freedom is 58% versus 8% with medicine. So that's where we're comparing it to. The best medicine isn't going to allow that patient to become seizure-free after they've tried several medicines. Usually after that second or third, the chance of becoming seizure-free is far less than 1%. So it's a big impact in terms of surgery. So even odds of 50 to 80%, and it's in that range of seizure freedom with surgery, it's worth it because it's so different than medical therapy alone. But it's not for everyone, right? And we have to make sure we evaluate every patient together. I don't want to upset you. You just had lunch. I'm not going to show a lot of brain pictures, but we do a lot of mapping of the brain, and we call this brain bingo in a way, but this is so important because we're trying to localize function in the brain and make sure that we don't interrupt, any of these pathways that control motor function and language and vision. And we can map those areas. The tools for imaging have just exploded for the last several years. We could do so much now, and I'll show you some of that, of how we can try to save function. Even when we study the temporal lobe, it's no longer where we just do something simple. We do visual naming to name objects, auditory naming, listening, and how we process information. All that can be mapped now, but we customize it. This weekend, Sunday, I operated on a piano player. We had to make sure we don't disrupt that hand, right? It's so critical. Also the right side of the brain, the music ability, So we're customizing, we're doing these surgeries awake sometimes, which are scary, but it's the best chance to make sure we can try to preserve function by doing that mapping, awake. And I promised I won't show too many of these, but we can map individual areas of auditory, visual. Sometimes they overlap and sometimes they don't. Here's an example of a patient we studied that was ready to get to his bar mitzvah. He was terrified he was going to lose his Hebrew. He just studied this for the last, 10 years of his life, and we're trying to cure these seizures. And he also had a tumor that was causing these seizures, very complicated. And we mapped out, with now imaging, in English, reading, and Hebrew reading, fascinating. They're not even in the same place. These languages are in very unique places, and then we can put together a map like this, which is naming in Hebrew, naming in English, reading in Hebrew, reading in English, all these different sites. It's a minefield we have to work around, but this was super important for this kid, right, to not lose that kind of function. And that's what we're always thinking about in a child or a young adult. Where Dr. Gallentine was talking about certain areas where the seizures are coming from, we might find areas like this, but sometimes this is where the seizures look like are coming from this area. So how much do we have to take? Obviously more is better from an epilepsy perspective, but less is better because you don't want to hurt function. So we're always trying to balance these risks. This is an example of a tuber. If you think of tuberous sclerosis, this is what a tuber looks like. It looks like a little potato in the brain. Super abnormal, right? And you think, oh, just take this out. Everything is simple. Not so simple, unfortunately, because Dr. Gallentine and team will tell you that the seizures were all coming from here, next to the tuber. And I got to take both, or the kid's not going to get better. So we're always thinking about how to do these things. How do we look at a imaging finding, which is a clue, but doesn't really tell you exactly what you need to do, for these patients. Lasers are very interesting. Here we are near the Star Wars exhibit, Disneyland. This is an exciting area. For us, lasers are interesting, but we're evaluating them a lot at Stanford because we're trying to understand, does this cause a long-term benefit? We're clearly helping patients in the short term, but we got to make sure it's durable over years, or it's not really worth that. The nice thing is we can insert a laser very deep in the brain and get to deep areas without doing open surgery. Well, that's nice. The patient goes home the next day. Transformative for temporal lobe surgery now. We basically do through the laser, especially in adults. So I think it's a very exciting time. Eventually, we probably will not even need to stick something in the brain. We're doing a lot of work with focused ultrasound to make lesions, say, for Parkinson's now, tremor. No question, epilepsy is next in terms of targeting deep areas. But we still got to know where to put it. Where is the target? If we don't know that, we can't just start making lesions around the brain. So I think it's a very exciting time, and the lasers have made some patients operable, where previously they weren't really, one to think about surgery. For some reason, patients don't think this laser surgery is still surgery, but at least allows them to come over and we can talk to them and then try to get them seizure-free because we're not doing a big open surgical resection. So I think this is exciting. This is an example of how we heat the brain with these lasers. This happens in real time in the MRI scanner where we heat that laser. We can watch the heat and watch our lesion. Super neat, right? Because it's real time. We're getting great feedback in the operating room to insert a deep laser to a focus right here and say the rest of the brain looks normal. I don't want to surgically go in there, but we can put a tiny laser less than 2 millimeters down into that spot. So that at least gives us options, but still, brain surgery may not be the right thing for people. There are other risks that maybe make someone more, at risk for seizures. And you remember the old operation game. We used to do this to our resident applicants coming through if they can actually see how their skills were, but they were so devastated if they hit the bone on the side. I can't do it anymore. It was just too devastating for them, so I had to stop that. But clearly there's vagal nerve stimulators, right? There are other options that we don't have to go in the brain, no question, and this has benefit. We don't have to target it. We don't know where they're coming from maybe, So vagal nerve stimulation is still here to stay. I've been putting these in since '98. You know, it's definitely still around. It's a good thing that it has helped many, many people. And then you get to something like this, which will scare you. But this is something where Dr. Gallentine talked about, this stereo EEG. And you may see in the exhibit hall, I encourage you to look at it, the ROSA robot. Have any of you seen that over there? But that is a device that has disrupted the epilepsy world in a good way. You know, it has allowed us to precisely place electrodes in the brain, not like this, don't worry, but to get to deep areas very precisely and in a very safe manner. That's way more minimally invasive than we used to do. And the neat thing is we don't have to shave hair, which is huge, you know, for the patients who are so worried about their hair. This is what we used to do. Big open surgery, putting grids down on the surface of the brain, timed within a week. We got to get the grid out, and then we got to do something. Big surgery. The worst thing is some patients, you get to all this and you find, just don't feel like we could do something. I mean, it's horrible. Put them through all this and then not be able to help them. You know, those days are over. You know, we don't have to do that anymore. Now we can put these electrodes in a much more minimally invasive way, tiny 1 millimeter holes, very efficient to put with the robots. Now the robot doesn't do the surgery, just want to make that clear. We still need surgeons. We're still doing everything to drill and put the electrodes in, but the robot is so nice to efficiently line things up where that surgery may take 8 hours in the past to put in maybe 12 electrodes in the brain. Now it's an hour and a half. It's a huge difference in terms of safety, and we can reconstruct this in 3D. We can put these electrodes in and look at the 3D network. So no longer are we on the surface, we're actually getting deeper in the brain into these 3D areas to look at that network, which is huge for epilepsy. We used to ignore the depth and just go to the surface. Nowhere near enough. Now we actually 3D print the patient's brain with the electrodes in, which is a great way at conference for the neurologists, and we rotate and can look at how these electrodes relate to one another and look at how they line up. The imaging here is so important. We're lucky at Stanford with super good MRI scans and imaging, which gives us the blood vessel map to avoid these and place these safely in the brain. This is the kind of detail we get. Tiny little blood vessels we can avoid with those electrodes. Very important to do this safely, because this step, remember, you're not helping the seizures. You're just still looking at how to treat that network. It's amazing, though, and it's happening more and more, where we put these in, the patient's seizure-free for several months. You know, what happened? Clearly, this is disrupting that network. You know, it doesn't like this. And then, you know, we're not going to touch the patient unless they're having seizures. But something is happening here as we're getting into those deep networks. And that didn't happen near as much with a grid, the surface, but in the depth, we're really capturing some areas. And this is changing what we do because we're now able to get much more refined and maybe find a small focus, that needle in the haystack, where it used to just project up to the surface, so we used to take out a lot more. So now we can really refine our resection. We can laser, we could do much smaller things. But it takes a lot of integration of all this data. You know, Dr. Gallentine talked about PET scans, SPECT scans, MEGs, all these different things. We build these onto one platform now. We have this platform called Synaptic, which is an amazing technology to integrate. We have 3 electrodes. Here we have the tracks. We have DTI, which is how the highways of the brain are all mapped out. We have the MEG scan. We can link all this together and figure out exactly what we need to do to treat a patient. So this is an example. Look how complex this is now with all the electrodes in, all the tracks, and we can figure out how to avoid that minefield, how to treat the onset. We also have to treat how that field is spreading, how the seizures start and we call propagate. So all this is super important. We can combine this on a map to look at tongue. This was actually a singer. You know, we're so worried about the tongue, obviously in speech and language. You know, we can't hurt those areas. You can laser or you can operate right up against them, but you can't go in those without causing a permanent deficit. That's not worth it. You know, so the hope is that we treat the onset, but we can't be too, you know, liberal around it because we're trying to get to a very deep focus, say right here, and avoid everything around it. Now we have the technology to do that live, in the MRI scanner to heat with all this information around us. Huge difference for us. So, the effectiveness depends on a lot of factors, right? MRI, positive or negative. Focal, one side versus the other, bilateral. Sometimes stereo EEG just nails it. I put all these in, we take hours planning it, we put the electrodes in. 24 hours later, they're telling me, we got it, we're done. I'm like, what? Are we that soon? After all this work? But I'm so happy to hear that, because then we're done. We can go right. It's so clear if we know that quickly of what's going on. But we're always worried about cognition, right? We always have to think about IQ and how a patient's doing in terms of risk. And I think we're thinking about how to get safer and safer. This is an example of, I don't know if it'll, probably won't play on this, but these networks, they may start here and they may spread to here, second focus here. So you sometimes have more than one focus. You have to see how one relates to another. And this is getting much more complex as we map all this. And it's fun, at a place like Stanford, you work with your computer scientists, your engineers, and really start thinking about this, of how to put this together patient by patient. This is so complex. Not one patient is like another in terms of what they're doing. And the last couple slides are really, present. We have a lot more options that are not just resecting, not just ablating with the laser. This whole closed loop responsive system, this is called NeuroPace, if you ever heard of that. We're fortunate where we are because NeuroPace, the company, is so close. There was a lot of interaction to get it better and better, where you still got to know where the seizures are starting. This is not a just throw them in somewhere. But once we know that, it's really interesting because it's basically like a continuous EEG. Once you implant this, you get tons of data you download as a patient, daily to understand what's happening and to help drive the settings of how to get someone seizure-free. The nice thing about this is you can insert electrodes like this attached to a stimulator that you put them in the brain in these areas you think the seizures are coming from. You're recording, and it's a smart device. It records something, boom, and then it stimulates to try to stop seizures and prevent them. So it's much smarter because it's localized to where we're putting these electrodes. Unfortunately, you can only put 2 in, either 2 strips or 2 depth electrodes. The newer ones probably will have 4. So it's continuing to evolve to allow us to treat, again, the network. The exciting thing here is we're not taking anything away. We're not ablating. We're not resecting. We're putting the electrodes in, and it's called neuromodulation. We're tweaking those neurons to how to make them seizure-free, again, without causing a deficit. So super exciting, I think, for the field to how to think about these kind of things. But, it has a battery. It's an implant. It's still a big deal. This is, I would not say non-invasive. You can't just go from a EEG right to this. You still got to do stereo EEG, still localize, and then find out, okay, these are the hot electrodes. These are where we need to put them. You can put more in, but you can only hook up 2, unfortunately. But that's going to hopefully change in the future. And even now, there's something called deep brain stimulation, which was just recently approved by the FDA, very recent, which is, we're not so sure where they're coming from. We think they're generated much deeper in the brain. They're spreading to multiple areas. Maybe they're bilateral. And those, in the past, we couldn't do a whole lot with. We used to do VNS. Now we think about deep brain stimulation into the thalamus, both sides, and we stimulate, neuromodulate those. And tremendous, I think, in terms of what it can add to the field. Not as good as the responsive NeuroPace, because then we know where it's coming from, but still very exciting, I think, and it gives a chance for patients that don't have a clear focus and are bilateral an opportunity to become seizure-free. I must say the last kid, if you remember he had tons of seizures, almost 15 a day. We put these electrodes in. We have not turned his device on yet because he's still seizure-free from those electrodes. There's a lot we don't understand in epilepsy, how this is all network together and why that happens. But I'm not going to turn his battery on. I don't want to waste the battery. He's already seizure free. How can I help him any better? But very exciting, I think, for a patient like that with not really clearly defined location to be seizure free, to put just 2 electrodes deep in the brain. Very exciting, but we have to combine all these things, right? This is the excitement, I think, of nowadays. We have a lot of tools. We just have to figure out how to apply them. Maybe focused ultrasound in the future. Our navigation is huge. Our imaging becoming better and better and better to find those deep areas. I must say, sometimes we do stereo EEG and we say, gosh, this focus is so hot. How can the MRI not show anything? But you go back and then you home in on that area, and then you might even do a 7 Tesla MRI and you see something. So you can go back and forth. You need to do that. And that's why your team is so important, because this is the goal, right? To optimize seizure freedom for a patient. The quality of life is so dramatic if we can get that patient seizure free, but we can't cause deficits, we can't impact cognition. And I think that's what we're all focused on. And I think I'll stop here, but maybe if you have questions, Gallentine and I can comment, or happy to talk to you afterward. But thanks for your attention. It's great to give you a glimpse into our epilepsy world. So,
any questions from the audience? Yes. So a VNS is basically a device that's actually implanted on the outside, and basically the electrode gets placed on this vagus nerve, and it runs actually up through the neck and then up into the brain. So it'll actually then send signals up that nerve, and so it's a kind of what we refer to as a peripheral stimulator. So it's kind of like indirect stimulation to the brain. Whereas a deep brain stimulator, the electrodes are actually in the brain in and of itself. And so it's direct stimulation. So it's actually applying, but it's oftentimes very similar in that they're both applying intermittent stimulation on and off, stimulating at various different times. And so, yeah, why don't you answer that?
yeah, it's a little bit different kind of device. There are 2 companies really that we used for the deep brain stimulator. Different than NeuroPace, so it's not a recording device. It's really just doing this intermittent stimulation. So one is deep brain stimulation, very different parameters than NeuroPace. NeuroPace, again, we have to know where they're coming from. If we found out where they're coming from and have more localized onset, NeuroPace is better, if we think, because that's going to be so much more specific. Most commonly it's used in bitemporal epilepsy because you have left and right. You don't want to hurt one side because you've got to make sure the other side's normal. But you can use NeuroPace to look at both sides and record from both sides over years and say, oh gosh, all the seizures were coming from one side. And that might lead to another procedure to deal with that because none of them actually did come from, say, the right, even though the EEG was kind of mixed. So that's where the RNS, the NeuroPace, is so much more helpful because you get those reads over time and it's so much more localized. DBS is where we're not really quite sure and don't have that localized knowledge, or if it's bilateral. And more for frontal, I would say, epilepsy, much more common. But similar probably pathways, everything's coming up through the thalamus, vagal nerve, same with DBS. The thalamus is so crucial, I think, for that input, but we don't usually record from those areas to really know what that means. So, yeah, good question.
Other thoughts or questions? Okay, well, we will, if there is no other questions, we will hang out down here for just a couple minutes. Feel free to come on up and catch us, or we'll also be at the booth at various times throughout the conference, so feel free to stop there. All right, thanks.
Thank you.